Mr. Chair, honorable committee members, I'm Dr. Dana Beyer. I'm Executive Director of Gender Rights Maryland, and it is my pleasure to speak with you today as a physician and surgeon. And it is my honor to read to you a letter from 5 eminent senior medical experts who are currently on staff at the Johns Hopkins University Department of Psychiatry and Behavioral Science. These are Fred Berlin, Chris Kraft, Greg Laney, Chester Schmidt, and Kate Thomas. These are their words and not necessarily those of the Johns Hopkins University School of Medicine. The Sexual Behaviors Consultation Unit has provided evaluation and treatment for individuals with gender identity disorder at Johns Hopkins for 41 years. It was the first clinic of its kind and remains the only such program located within a medical institution. Through the clinic and through our combined private practices, we have seen hundreds of people with the diagnosis of GID. In our practices, we follow the standards of care of the World Professional Association for Transgender Health. One of the most basic requirements of the standards of care is the real-life experience. This requires that individuals going through the process of sex reassignment undergo an extensive period of living full-time in the role to which they aspire. The purpose of this requirement is that people develop a realistic understanding of the difficulties they face in changing their sex before they undergo hormonal treatment or surgery, so that if they are not prepared to deal with these difficulties, they will desist in the process. Relatively few people stop their transition. Overall, the satisfaction rate is 99%. Still, some 30 years later, this remains controversial for a few, but we believe that most people treating individuals follow this model. Some individuals undergoing the real-life experience encounter significant harassment and discrimination, which at times may be life-threatening and lead them into encounters with the police or emergency medical personnel. When transitioning individuals request, we provide a letter testifying to their status. They call this a safety letter, although of course it does not actually protect their safety. We consider it unfortunate that we need to provide any of our patients with such a letter, but we have heard many stories from individuals who were treated unfairly and humiliated by others in the process of trying to live in the role of the other sex. There has been concern on the part of the public about possible incidences of sexual crimes in bathrooms perpetrated by those in a cross-gender role. Over the years, we have evaluated and treated many men who engaged in sex offenses and many men who have cross-dressed. We have not encountered a single man who cross-dressed for the purpose of committing a sex offense in a women's bathroom or other setting exclusively occupied by women. Gender identity disorder is a very real condition and not due to a delusion or other form of psychiatric illness. The origin or cause of GID is currently unknown. However, it is clear that there are a number of individuals who feel that their internal sense of who they are, their gender identity, is at odds with their natal sex. Living as the gender opposite that to which one is born is the accepted medical treatment for this group of individuals. Our experience, as well as that detailed in the literature, points to the fact that those who adjust in their cross-gender role make outstanding and productive citizens whose rights need to be protected. I will personally conclude by saying that it is expected that this coming May, in 3 months, the American Psychiatric Association will approve the updated language regarding this condition, depathologizing gender identity disorder as a mental illness and calling it gender dysphoria. I am honored to have been a part of that process. Thank you all very much. I ask that you approve SB212.
Thank you, Doctor. Senator Raskin has a question.
Dr. Beyer, just one quick question. So you say that this is gender dysphoria, gender identity disorder, and yet it's not a mental illness. Will you explain how it can be a disorder but not a mental illness?
Well, it really can't be a disorder, but that language, that nomenclature was put into the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, back in 1980, when many people did consider it a disorder. The 5th edition, the major revision, the first one in 20 years, is happening this year. It will be published next year. And the psychiatric community now, overwhelmingly by consensus, has depathologized it. So it is no longer considered a disorder. It is simply considered a congenital neurological, neurodevelopmental condition. So it's no longer disorder. Having disorder in the title is stigmatizing because it is not a mental illness.
So what you're saying, this is sort of a roll of the genetic dice where somebody ends up with a medical disorder, but it's not a mental illness that they carry with them their whole life.
Correct. This is a fundamental neurological condition. There are hundreds of intersex conditions. This is one, which is one of the most common, but it is not that unusual. We make up 0.3% of the national population.
Thank you.
Any further questions? If not, thank you very much, Doctor.
You're welcome. Thank you.